There are a lot of teens watching this. How about starting with your journey, right from 8th to 9th standard, start preparing for NEET, and if somebody wants to become a doctor.
This is one field which is very demanding.
Why is physics and chemistry required? I should only study biology.
I can relate to his question.
Everybody has to do their MBBS.
Yes.
Right? And after that, this field of super specialization comes in. So there are three types of oncologies.
So it is not that you can pick it up directly after internship within the three fields. Now we have people who are doing molecular oncology.
Cancer is where the cells grow and multiply at a faster rate than normal.
These are not normal cells which are growing.
Okay.
So elementally, what is happening, the DNA of these cells is defective. Last year it has come out to 14.5 lakh new cases every year we are seeing. And the predictions are even worse.
Why is this happening? I mean, it's lifestyle, food habits, the stress that we are taking, while we are on the job.
I think the contribution of diet and lifestyle in causing cancer is almost 40-50%. We just recently released our book on complications in oncology, the best practices in prevention and management. So this is particularly targeted to the medical fraternity, and in that also, not just the doctors, even the nursing staff, as well as the students who are still under training. See, now we are having a higher cure rates. We are seeing patients live longer.
How can we look at avoiding cancer? And we see a lot of heart packages available.
Yes.
I don't see anywhere cancer packages. I think it is more necessary than ever. With the kind of exponential rise that you are talking about,
you can avoid cancer. There's a big banner there right at the reception area which they have mentioned cancer screening packages. It's absolutely free service where any woman can go for a free pap smear. Any woman who's more than 40 years of age can go for a free mammography. Any gentleman above 50 can go for a free PSA examination.
What are the most common types of cancer?
Breast cancer in women is the most common. Second most common is the cervical cancer.
What I've also heard is that breast cancer is more prevalent in the cities than in the rural areas.
That is absolutely correct. Breast cancer is a lifestyle disease.
If mother and father both have had cancer, there's a very high chance that the child will also have cancer at some point of time.
So it is not that simple.
If somebody is suspecting that they have cancer and they want to go to a hospital and start their treatment, who should they go to first?
Cancer centers build in the infrastructure in such a way that everything is under one roof.
What are the different types of radiations that are there?
Radiation is of two types. It is particulate or it is photons.
Why a doctor should study physics? Here the answer. Younger people who get cancer are more prone to a very aggressive kind of cancer. If we detect cancer earlier, it is curable.
And you can avoid it. I liked your line. I liked your line. You can avoid it.
Hello and welcome to Tech Talk with KD. Today we are going to talk to a doctor. Yes, you heard it right. We are going to be talking to a radiation oncologist. Should we then call it Med Talk with KD? Good food for thought. We will definitely think about it. For now, let's welcome Dr. Kanika Sood Sharma. Dr. Kanika is the Director of Radiation Oncology in Dharamshila Narayana Hospital in Delhi. It's an honor and a privilege to welcome Dr. Kanika Sood Sharma. Hi, Dr. Kanika. Welcome to Tech Talk with KD.
Thank you. It's an honor to be in your show. I'm really, really excited to have a great conversation today.
Sure, ma'am. So, ma'am, I was actually, going through YouTube and I was trying to find more and more podcasts on oncology, and I actually could not find a lot of material over there, especially on radiation oncology. Could not actually find any material at all. So, and that is what also prompted me to reach out to you, to talk about and create more awareness overall about cancer. We'll talk about radiation, we'll go deep into radiation, but we would want to actually talk more about cancer as well. So that's where I thought I reached out to you, and thank you for obliging and coming on to the show.
Most welcome. I think you've rightly said that very less content is there about oncology, particularly radiation. So much so, one of our colleagues, from the medical community asked me that, am I doing ultrasounds? So I was surprised to see that even our own community does not sometimes have the ability to differentiate between a radiation oncologist and a radiologist. So sometimes there are some niche fields where the community is not aware of the fraternity. So I'm glad that I will be able to, put out to the community that yes, there is an oncology community which is dedicated for radiation.
Absolutely. And as we were talking earlier, you come from a family of doctors. How do you, ma'am, manage your time between work and life? Because I see you in the hospital at 9, I see you in the hospital at 1, I see you in the hospital at 6 in the evening. Just for the audience, ma'am is also the oncologist for my mother. So that's how I keep visiting the hospital, and I keep seeing ma'am over there. So, ma'am, how do you manage the work-life balance?
So I think that is one thing which is to my favor, because all our doctors, so they understand the pressures of being a doctor, and with their own experience they know how much time we need to devote to this profession. Because see, all of us have picked it up by choice. So when you make a choice, you have to put some extra effort to live up to the expectations to everybody around you. So fortunately, I have a very, very good support system with me, because the people supporting me behind my back, my parents-in-law have been doctors. So they are giving us those wings to fly, and they make it sure that there is sufficient air beneath that wings as well. So I think I would give a huge credit to their understanding of this profession, and that really gives you a lot of comfort that you're not doing it on behalf of missing out something from the family end. So they are ensuring that our kids are well taken care of, and we feel safe, and that is why we are able to devote more and more time towards our work. The other thing which is important, I think, for any woman, not just me as a medical professional, you really have to learn multitasking. It is all skill of multitasking. So you have to be a very, very good time manager. You have to be very organized if you are wanting to do a lot of things at one go. In case you are not a good time manager, you will have some struggle in tripping on that balance of work life.
Absolutely, and that's so true in each and every field. Even in my field, I'm a techie. What I'm also seeing is being a doctor, you are so active on LinkedIn. Normally, I see all the techies. I belong to the techie field, so I see all the techies being there. But it is so good to see you. In fact, I would kind of take a step back and say you are also a techie, right? Because you look at radiation. Radiation is hardcore physics.
Yes.
Married to hardcore medicine, where you are actually saving lives, and you're so active on webinars. Yes. You keep doing seminars. You've agreed to come on the show just to create awareness about cancer, and you keep doing such stuff. It's really amazing, ma'am. I just wanted to appreciate that.
Thank you so much. I think it is something which even I came to a realization pretty late. So I was on LinkedIn for years together, but I could not understand the visibility of LinkedIn in the community. I came to a realization that if you're doing good work, especially if you're doing good medical work, there is an audience who wants to know what is being in place in oncology, what is happening in medicine. So the media for that is LinkedIn. I found LinkedIn as a safer space. I felt that LinkedIn is a safer space, has a more wiser audience. The people who engage with you from LinkedIn are wiser, and the network which you built there, it is not just for your practice. You get to know a lot of people beyond your fraternity also. So it's a journey. I think LinkedIn is not just about showing off what you're doing. It is also about learning a lot from others.
LinkedIn is going to be happy about this, right? So, ma'am, I would want to start from the start, right? So, would like to talk about your journey, because there are a lot of teens watching this. My son wants to become a doctor. I have similar questions. So it is, for my benefit also, I wanted to ask, but it is a general trend. Everybody, wants to understand and know what is the right way to go about. So, how about starting with, your journey, right from 8th to 9th standard when you were there? That is when I hear people start getting into these classes and different coaching classes, start preparing for NEET, and if somebody wants to become a doctor. So how did you plan your journey? And based on that, what should the kids also of today do?
So I think first and the foremost thing is, don't do it just because others are doing it. Don't do it because your parents want you to do it. You should have a passion for it. Because this is one field which is very demanding. And it's not just a matter of those 5.5 years or maybe not the 3 years of super specialization. It's a lifelong of investment of time. And it demands a life of devotion also. Because if you want to be a good doctor, you cannot sit back. You cannot have a plateau. There will be never a phase when you'll say, ab sab kuch ho gaya. Now everything is good, now I just sit back. So there's no sitting back in this profession because it's changing. It's a very dynamic field. Every month, I would say rather every alternative week, there would be something new coming and you have to be reading, you have to be practicing these things, you have to be updated. So you should have a passion for it. So only do it if you have a passion for it, because if you have a passion for it, then irrespective of what coaching you do, I think you can pull out and reach out to what you want to be. Talking of my own journey, my realization came in very early. I think I must have been one of those children who at the age of 2.5, 3 years realized I'll be a doctor. So
because your dad was a doctor.
Yes. So sometimes when I look back into my family albums, I have few pictures where I am a toddler and I have this stethoscope and I'm examining some laborer or somebody around, and these are small those black and white pictures. You can't even figure out who this person is. So I keep asking my mother. So she tells me that my grandfather used to say that your daughter every day, the whole day, she's examining my chest with stethoscope. So it was like I saw my father practice, so it somehow, I imbibed that profession into me. I never thought of it as a second thought, it was always there. So over a period of time, when you somewhere in 5th or 6th, I was still in my, those early teens, my mother got breast cancer. So that was the time when we saw this particular disease from the family end also. So that passion to be a doctor was there, but then understanding oncology, I think oncology came into my mind at that point of time when I realized that there is something which is very scary, because as a child nobody was talking to me about it. I could hear hush hush, my maternal grandmother and aunts talking about those surgeries. I didn't know what is BCS, I didn't know mastectomy, but I could understand what they were talking about. So at that point of time I realized that there is some field in this medicine which is very, very scary. That is how it came to me at that point of time. But then when my mother went through her treatment, I saw her recovering comfortably. I realized that no, it's a good field. My mom is hale and hearty, and my professor who ultimately became my guide was my mom's doctor. So I used to sometimes accompany her for visits. Very few occasions I accompanied her for the visits, and I really used to adore him. Like he was like a god figure to me. So that passion added on to that family end of looking at the disease probably had already ignited the fumes of being an oncologist. So it was always in line. But somewhere down the line when I entered MBBS, I had different choices, because then you're exposed to many more branches. So I was not the person who went in for coachings, because I am one person who will read the book from cover to cover. So that was my modus operandi. Any subject, you give me any book, I will read it from cover to cover, including the preface and dedication. Because if you have read it cover to cover, what are you missing out? I was like, syllabus ke bahar aur kya hoga? I've read everything available to me. And I used to read all information, all books which anybody would tell me to read about.
So you were that kind of a girl at that time. There is an idiom, एक कहावत है, right, कि डॉक्टर जो बन रहा है उसको सोते हुए भी पूछोगे दवाई का नाम तो वो बता देगा.
Absolutely. And I think I was solving numericals in my dreams, and physics was my strong area. And since you brought about that physics tech factor, so I remember walking out from the hall after the pre-medical examination, we used to call that PMT. When I was walking out, everybody was like, complaining, physics was so tough. I did so well in physics. I was so happy with my physics exam, and that was my, mantra.
point.
That was my mantra, and I made it in the first attempt without any coaching, because I had really put in a lot of effort in physics.
In fact, my son reached out to me a few months ago and said that, Papa, why is physics and chemistry required? I should only study biology.
Absolutely.
Why is it required for, he's 14 years old, why is it required? So I gave him your example first, that this particular field requires it. Then even dentistry, those mechanicals and all those things are required. Chemistry is required for medication. So I explained him all that.
I can relate to his question. I asked my mother, why do we have to read mathematics? If I want to be a doctor, why can't I get rid of mathematics in 8th? Why do I have to wait till 10th standard?
He does the same thing. In fact, he told me that, I am not going to take mathematics after 10th. Even though he's very good at maths, he's like, I don't enjoy doing it.
But I think with more wisdom at this point of time, I would suggest he should carry on taking maths till 12, because maths is required everywhere. It is not just as we see, even in the medical science, a lot of things, statistics is purely mathematics. So when you're into research, when as a doctor you venture into research, you are adding numbers, that is the time you realize I should have taken maths, a bit more.
This is a very good suggestion to all the youngsters out there, that physics, chemistry, maths, biology of course is there, but physics, chemistry and maths is also very important, and they should keep maths, even for this profession, they should continue looking at maths seriously.
We as Indians, I think this is one of the biggest advantage we have. Our mathematics is better than many other countries. So, that gives us an edge. It gives an edge when you're competing with people from different countries. I'm not talking of just competition inside the country. If somebody goes out and you have a better edge in mathematics, you are good at pure sciences as well, somewhere down the line in the research, you will have an upper hand.
Okay, cool. And so after that, after you cleared your PMT, you went to normal MBBS college, right? So everybody has to do their MBBS.
Yes.
Right? And after that, this field of super specialization comes in. Right?
So MBBS is a prerequisite in the medical field. So after you've completed the academic journey of MBBS, then you have to intern for a year. So internship is where you have completed your exam. There is no examination, but you're being exposed to different fraternities. You're meeting every fraternity, be it pediatrics, medicine, neurology, surgery. So you are rotated across. So firstly, it gives you a little bit basic confidence of practicing as a general physician. As a generalist, you can do a little bit of fair practice. Secondly, maybe that is the time you actually figure out what you want to do. Okay. So as I mentioned, that time I was in that era where I felt that probably, I would pick up a surgical side. So there will be these phases where you will be, lured towards different phases. And I'll tell you why surgery. Surgery gives you the biggest kick factor. When you're doing something, you're opening up a person, you're sewing him back. It gives you a lot of ego thrust. So most people, in medicine, they feel that surgeons, are doing a very great job. But then with time you realize that there are other fraternities also who in their own space are doing equally well job. So over this bit of permutation, combination, whether this, whether that dilemma remains. But then clarity came. My husband, he told me, you take radiation oncology. I was the topper of the batch. So everybody was surprised. I left radiology and I picked up radiation oncology. Even the people who were sitting on the panel, they said, we are repeating, you're not taking radiology, you're taking radiation oncology. I said, yes, I'm taking radiation oncology. And our principal at that time, he was a radiation oncologist himself. So he was very happy. He was beaming with pride. And he says, welcome, I'm so happy you picked up radiation oncology. So I went out after the counseling, I called him up. Then not my husband, so then we were seeing each other at that time. I said, I took radiation oncology, but what big advantage you feel in this subject? He says, see, it is an upcoming field. When you go back, looking for a job 5 years from now, it will be one subject sought after. There will be hundreds of people doing surgery, there will be hundreds of gynecologists, oncologists will be few in number. And probably he felt that, he saw that in me, because being a senior had seen me academically grow also. So I always thank him for that. I keep thanking him. Your mentorship has always been great. So when I joined radiation oncology, I loved the subject. There was no second thought about it.
So just taking a step back, ma'am. So after MBBS, you did 1 year of internship, and then you decided on which oncology you
Yes.
have to go to. But there would be other fields too.
Yes,
So
yes.
within those fields, you said that, okay, I want to go. Oncology is study of cancer for all the audience. I would like to state that. So there are three types of oncologies, right?
Yes.
If you can just touch base on those, point by point.
So oncology has three pillars. So the three big pillars are surgery, medical oncology, and radiation oncology. So it is not that you can pick it up directly after internship within the three fields. Radiation oncology is an end field. You can take it directly. For surgical oncology or medical oncology, first you have to do a specialty. It's a super specialty there. So if you have to be a surgical oncologist, you need to be a surgeon first. So first 3 years, you will devote yourself to surgery and then again compete through the NEET exam to select a subject. So if somebody has pursued surgery, then he can decide whether he wants to be a GI surgeon, a neurosurgeon, or a urologist, or a cardiothoracic surgeon, or a surgical oncologist. So the choice comes after you have completed the 3 years tenure of surgery.
Oh, okay.
So is for medical oncology. For medical oncology, you need to read medicine first. Medicine and a few pediatric specialists are also eligible to do pediatric oncology. Radiation oncologists also can further on pursue the course of medical oncology if they want to devotedly just do chemotherapy. So radiation itself, it's an end branch. You need not do those 3 years of surgery or medicine. You can directly pick up this field. But surgical and medical require this. Then I would say now, not exactly pillars, but now we're having more elements to the infrastructure of oncology. Now we have people who are doing molecular oncology. These are people who are hardcore genomic people who are analyzing our DNA to identify the mutations, identify which drugs might work for this patient. So they are called molecular oncologists. So they are the people who have come from the pure science medical end. So for that, you can directly pick up molecular oncology. Molecular oncologists are also helping in genetics because few cancers are genetically associated. So they are the people who are also, engaging into finding the pedigree of the patient, trying to figure out whether the rest of the family members might have some risk of cancers, whether they need any surveillance. So this is another field which has come in. And with times, I think there will be more and more end specializations. Okay. Like even in the surgical oncologist, now people are picking up organs. For example, if there's a surgical oncologist who's just doing surgeries for head and neck area, we call him head and neck oncosurgeon. Then there will be somebody who's just doing dedicatedly breast surgeries, then somebody dedicatedly doing only GI surgery. So oncosurgery, a step ahead would be then the organ specific. We call them disease management group based practice, where people are only treating one particular organ. So this is the reason when I said that, pick it with a passion, because the trail is very long.
Yeah, I mean, I actually did not know all of this. Thank you for shedding so much of details onto, how to go about. Just wanted to touch base on a very, very, very basic point here, for the audience that and for the awareness. So my understanding of cancer is that we all have cells, and these cells multiply and they grow, right? Cancer is where the cells grow and multiply at a faster rate than normal, right? And that gets developed into a cancer. The most basic definition that I can understand. Is that understanding correct?
So partially, I think the uncontrollable growth element is absolutely correct, but these are not normal cells which are growing. Okay. So elementally, what is happening, the DNA of these cells is defective. Okay. So a normal cell has a cell lifetime. It develops, it grows, and once it is not of use, either there will be an autophagy, we call it cell senescence. There are telomeres in our chromosomes which define the age of the cells. The cell dies and the body disposes of the remnants of the cells, and that is it. However, sometimes because of some mutations, which could be because of some carcinogens in the environment, anything, whatever triggered that DNA to become defective, now the DNA is unable to identify that it is time to die, right? These cells, these defects, we can't repair them because there is something wrong in the genomics. So now these cells, which are defective cells, they are like parasites to the body, they're not of any help to the body, they start growing uncontrollably. So that is cancer. So these are abnormal cells and they're of no use to the body. Once they are breaking, they can spread to the other parts of the body. They can go and invade the adjoining areas like the nerves, the veins. That is the time patients will start to appreciate pain or bleeding. Those symptoms come in when it starts infiltrating.
Ma'am, you would be seeing cancer patients day in and day out, right? Throughout the day, you keep seeing cancer patients. Just wanted to know that over the past few years, has there been an increase in the number of cancer patients that you used to see earlier and you used to see now?
Yes. I think it's not just me. It is on paper that the number of cases are rising tremendously. If I can give you a fair figure, the WHO, the data set they put onto their website, it was around 9.5-10 lakhs in 2018 or 19, and last year it has come out to 14.5 for India. 14.5 lakh new cases every year we are seeing, and the predictions are even worse. So we have few journals who are giving a lot of epidemiological surveys, and one of them you will be knowing the name. It's a very famous Lancet journal. So Lancet gives a lot of information with regards to the public health issues which are likely to come up in the coming 10 years, in 20 years. So what the predictions came last year are actually alarming. Two big predictions which I really feared is, first prediction was, of course, cancer is on a rise. They said the people less than 50 years of age will die of cancer. There will be a 46% rise in that rate. That means we'll be losing a lot of young lives. The breadwinner population is likely to go. The incidence is going to rise by 20-25% in youngsters, but the death rate is also proportionately rising, almost double the incidence. Second thing, which was again very bothering, a big paper came for prostate cancer. They mentioned that prostate cancer in developing countries is going to rise by 63%.
63%.
And the numbers would be so high that the medical facilities will fall short to treat these patients. And a disclaimer which they have given at the submission, they said that even the preventive measures now may not control the things to the extent we want them to be controlled. And what are these diseases? These are practically lifestyle diseases. These are all diseases which we are buying for ourselves. So this is very alarming. Like, it is not just about the incidence which has been increasing decade by decade. The lifestyle change in the last 10 years has been so tremendous that we are going to have a pandemic of cancer.
That is that actually you dropped into my next question, which was, why is this happening? I mean, it's lifestyle, food habits. I mean, because if we look at, for example, sports athletes, right? I have not seen many sport athletes most of the sport athletes actually get cancer, except, I mean, you have an example of Yuvraj Singh. That was also a different kind of cancer, but I haven't seen sport athletes get it. So is the lifestyle, the sedentary lifestyle that we are in, the stress that we are taking, while we are on the job, is that, to an extent getting responsible for cancer creeping into our bodies?
So if you see the contribution, I think the contribution of diet and lifestyle in causing cancer is almost 40-50%. So if I break that, if it's a pie chart, if I give some values to that pie chart to different causes, 30% of cancers are related to tobacco. Almost every year, 3.5 lakh new cancer cases in our country are attributed to tobacco. That could be cigarette, bidi, even the chewed tobacco. In our country, chewed tobacco is more common, so we see more oral cancers, tongue cancers, cheek cancers. There was one study from Tata. Before COVID, they had mentioned that there is a 117% increase in the oral cavity cancers, the mouth cancers in our country. And that is purely because of the chewing habits, because the chewed tobacco, it stays in the mouth in different corners, it irritates the mucosa, and that leads to cancers. Another big proportion is our diet and lifestyle. So what is defective in our diet? When we are taking more processed foods, foods which are less in fiber, foods which are more lardaceous, they are causing abdominal obesity. The obesity which comes over our tummy region, we call it truncal obesity. Truncal obesity is bad. It is responsible for almost 4 different cancers: breast cancer, prostate cancer, colon cancer, endometrium cancer, the cancer of the uterus. These are attributed to our abdominal fat. So what is happening in this fat? The fat is also a factory for few hormones. There are some hormones which are coming from the ovaries in women, testes in men, but some fat is also built up in the fatty tissue of our body. So this particular area becomes a factory for extra hormones. Simultaneously, these diseases are this abdominal obesity are also triggering more diseases like hypothyroidism, diabetes. So a metabolic imbalance in the body can trigger formation of cancers. So particularly if you talk of the endometrial cancer, we always say there's a copper striate syndrome, a woman who has diabetes, who has hypothyroidism and is obese. So she has all 3 parameters to get a risk of endometrial cancer. So this is the risk of lifestyle. So we really need to work on the abdominal obesity. It is not just the overall weight, it is the distribution of the weight which is also important. Second thing, our physical activity is so less. When you are not doing any physical activities at cellular level, your body is degenerating day by day. People who are health freaks, they know that even after 35-40 years, 0.8% to 1% your muscle mass is slowly vanishing out of your body. So the good portion of your body, the bodybuilding part of your body is going, that is also not good for your health.
And if you look at the Indian diet, we don't see a lot of people paying more attention to protein intake, right? And
so the traditional thali was good. I would differ there. If you look at our traditional Indian thali, you would find curd there, you would find a lot of fiber there,
right?
And you would find a dal every day in your plate. So these were good sources, and non-vegetarians had non-vegetarians also. The meats, the lean meats, the white meats were there. Now what is happening is the component of protein is less, and the white breads, the processed breads are more. So that is which is detrimental. And then less antioxidants in our body. When you're taking greens, when you're taking colored fruits and vegetables, you're taking a lot of antioxidants. So these antioxidants at the cellular level help reduce stressors. When you are stressed, your body releases cortisols. So at cellular level, these cortisols are degrading the cells. So DNA में जो changes हैं, where are they coming from? In some format, they are these cellular level stresses. The ecosystem of the cell is getting disturbed. So there are a lot of cancers associated with viruses also. I think you must have heard of human papilloma virus vaccine, which was much talked about recently. In the budget also, they've kept a provision this year for vaccination of the young girls.
Yeah.
So there are certain viruses, we call them human papilloma virus, and they are almost 8 to 10 strains. Rather, there are much more strains, but these 8 to 10 strains are the ones which are the worst. So they are responsible for causing cervical cancer, penile cancer, anal cancer, warts, and even oral cancers. Oral cavity, the oropharyngeal cancers particularly are attributed to these viruses. So if we get vaccination done well in time before the children get a sexual exposure. So if vaccination done in time is there, then the risk of getting human papilloma virus associated cancers is less. And 95% of cervical cancers are because of this virus.
Oh.
The numbers are going down. Fortunately, in our country, cervical cancer was #1 cancer in women. Now breast cancer has become #1, cervical cancer has become #2. So if vaccination is done, and then there are certain tests like pap smears, which every woman should go for every 3 to 5 years. So if that is done, then we can pick them early. Because see, the biggest thing in cancer is picking in time. If we pick it in stage 1, we know 80-90% cure rates are there. As the stage of disease progresses, we pick up late. Firstly, the chances of cure go down. Then the number of treatment modalities which you require to treat increase. As a first stage, it's maybe just the surgery and hormone. By stage 3, you will have surgery, radiation, chemo, hormone. So not only the financial, toxicity increases, the complications, the side effects of these treatment also increase as the treatment gets delayed in time.
Right. So, ma'am, talking about complications, I was seeing on LinkedIn, I saw you actually launched a book. You were there at a book launch.
Yes. So we just recently released our book on complications in oncology, the best practices in prevention and management.
Wow. Okay. And this book is targeted. Who's the target audience for this book? Is it the general people, general citizens, or is it the medical fraternity?
So this is particularly targeted to the medical fraternity, and in that also, not just the doctors. even the nursing staff, as well as the students who are still under training. It is going to be a very useful resource for all of them.
So ma'am, what actually inspired you to talk about the complications? Did you see a gap in the clinical findings which are already there?
So there were two things I would say. Firstly, I felt that, complications are like, people fear talking about them, as if, you have done something wrong. It is not that a doctor has done something wrong or something wrong has been done to the patient intentionally. So people don't talk about complications. So that is why if you look at books or if you look at resources, they're talking of complications towards the end of the chapter or towards the end of the reading. They will mention that this is the rate of toxicity which we see. So I could see that we are not talking about a thing which is of importance. And why is of importance? Because see, now we are having a higher cure rates. We are seeing patients live longer. When they live longer, they have to have a quality of life. The quality of life is affected by complications. So this was one factor where I thought it is required. Secondly, even in our clinic, sometimes if you see something which is out of proportion, you start to look at the medical literature, you find things in silos. One topic is there in one resource, one topic is there in some other resource. So there was not a one-stop shop sort of a thing where at one glance, I have everything in hand. So the courage came after doing one conference. I did a conference in complications in oncology, where I really would want to credit all my dear friends and colleagues who came in. They very discreetly talked about the complications they have seen in their clinics. Nobody did that hide it below the shrug attitude. They talked about complications, they talked about mistakes, they talked about errors. And there was a big segment on how to communicate to the patients also. If there is something wrong, how patients should be knowing about it. Patient has to know about it. You can't just put it in paper and hide it off. So that whole conference was revolving around complications. So then I felt that, people are very, very open in talking about it. They will be open in sharing their expertise in form of a manuscript. So that was the trigger, and COVID was the time when, as clinicians, we could spend some extra time towards, this work. Otherwise, as medical practitioners, we are so busy across the day that thinking of a book is like out of question. And I still remember, very early on in my career, I was just authoring few chapters of a textbook. So I told my father-in-law, I'm authoring textbook chapters. So he says, "Velon ka kaam hota hai." So I told him, "मैंने वेलों का काम कर दिया."
That was a nice one. But I really think, this step is very important because I can actually relate to it. If the patient knows about the complications beforehand, what they are getting into with a particular treatment, I think it makes a world of a difference, right? It leads to a better patient experience, I think. So knowing about the complications beforehand, I think it leads to a better patient
I will
experience.
totally agree upon it, because whenever I am counseling my patients for treatment, and I even jot them down, sometimes when you are coming to the clinic, that time you're very anxious. Sometimes you don't want to hear those bad words. Yeah. So you have a selective acceptance. You only pick up the words of choice, you pick up the good ones. So I jot them down also on the paper, that this is the likelihood of, risks of these things happening to you, so that, they know it there. And then I always reassure, I'm not scaring you. I'm trying to tell you that everybody gets some proportion of these side effects, and these will be manageable, and these are part of treatment. And even in this book, the first chapter, I have put a statement, which is a very famous statement by Dr. G.K. Rath, who had retired as director of IRCH, that there are accompaniments. Some things are part and parcel of treatment. So that need to be known by the patient. And even if they are not part and parcel, even the rarer ones which might happen should be briefly discussed, at least to the extent that they are not scared of. Because see, as a medical community, we are also worried. Sometimes what happens, patients fear treatment. Particularly cancer treatment, patients, what they do is they try alternatives for the fear of side effects. So at the same time, we don't want that they get so scared that they say, I don't want to go for such a treatment where I'm anticipating so many side effects. So there has to be a trade-off on to the extent how it is told and who is told. Sometimes, the caregivers are more wiser. Patient is in a very anxious state. So maybe you can give them some information to the extent they can absorb, and rest of the information remains with the primary caregivers. At least the caregivers should have full information. That is how practices in India. If you see overseas caregivers don't know anything. It is the primary patient who knows A to Z about herself or himself. So that is how practices here. We try to give in more and more information to the caregivers, because they would be handling most of the patients related, logistics, their nutrition. So that needs to be discussed in the first counseling itself.
And this book actually has details and complications and management of complications related to all the fields of oncology, right? Whether it is surgical or medical or radiation.
So it's a very extensive resource. It has 47 chapters.
Oh,
and you believe me, it is 2.5 years of toiling, and it has been like a lot of sleepless nights. And another thing was that when this book was in process, at the same time I was pursuing a course from IIM Bangalore. So my paperwork, my group projects and my assignments paralleled the submission dates many a time. So it was like walking on a tightrope day in and day out. But since I mentioned this course, the final project of my course, you have to present a capstone project, was again on patient counseling. So that is what I feel is a big lacuna in the medical community, and majorly whatever distrust or fights or anything happens in the healthcare sector are because of gaps of communication. So that groupstone project was aimed towards that.
So ma'am, with the advent of personalized and precision medicines like immunotherapy, and there are very precision medicines being delivered, you do the treatment with a lot of precision as well. How do you think that this book actually allows the oncologist to tailor their approach towards giving the treatment?
So since this book has a resource across all the oncology modalities, if I talk of radiation, so there are chapters where we have mentioned about predictors, where you can anticipate that this is the patient with this profile, she or he is likely to have more of these side effects. So how from our radiation element, what changes we can do, how can we change the alignment of the treatment or the dosages to reduce the risks. So there's a lot of talking about predictors and anticipating side effects in advance in many patients, and take prophylactic measures. So there are some prophylactic medicines, there may be some alternative treatments. If you have two treatments which are head to head giving same survival, same cure, then choose the one which is giving lesser side effects. So that all has been talked about in this particular book.
So what's next on your journey, ma'am? What other sides of oncology are you going to explore further?
So as I mentioned, this capstone project of mine which I presented in IIM Bangalore final submission, so it was talking about counseling the patient before they even enter your clinic. So since you have seen hospitals so many times, doctors, we have limited time.
Right.
Sometimes your consultation would be not even more than 10 to 12 minutes. And there'll be a lot of unanswered questions, and you yourself will feel that, I had so much more to talk about, but see, you also know our pressures, you also know that times are limited. So this project was about creating a lot of resources which patient can see before even meeting us. And validated resources, not random, not that they do a Google research and they get up with a lot of unvalidated information. It shouldn't be a confusing information. So what we did for this project, I created an entire set of video of radiation planning. What would you expect during the radiation planning? From the entry from the door, how it would be made. It was a full video.
Oh.
So if the patient sees, so he's or she's primed on what is going to happen. So what happens is many questions are addressed there and then, and there may be some questions which now he has and he's able to ask by the time he comes to me. So the dedicated, information has to be done. So that would be formalized into a book, because I already have a channel, Health Talks by Dr. Kanika, which has a lot of information on do's and don'ts, what to expect in what treatment, what is the right treatment for a particular disease, how to proceed, what is screening. So that in a patient-friendly language, I would want to bring into a manuscript form, so that there is a one-place resource on to cancer caregivers as well as patients. So that is in my mind, and work is already in progress in regard to that.
Wow, we would wait for that, ma'am. How can we look at, avoiding cancer? I would not say avoiding cancer, but let's say, early detection of cancer. And we see a lot of heart packages available.
Yes.
I don't see anywhere cancer packages. I think it is more necessary than ever. With the kind of exponential rise that you are talking about, I think, and this is a suggestion which I'm giving to all the hospitals via this chat of ours, that there should be some packages for checking out cancers as well. So cancer package for detection, early detection of cancer, if there is anything alarming that can happen.
So I will say your first statement was also not wrong. You can avoid cancer, right?
Okay.
That is when you reform yourself. As we said, 40 to 50% of cancers are lifestyle.
Yes.
So if you reform yourself, you are likely to reduce your risks per se. Don't smoke, you're avoiding cancer. Don't consume these fancy products of alcohol and combination of tobacco, because they are synergistic. Alcohol causes food pipe cancers, it can cause stomach cancers because of irritation. Even these hookahs, these shishas, an hour of smoking of shisha is equivalent to smoking 100 cigarettes. So you can avoid cancer by avoiding these known agents. A cigarette has almost 700 chemicals, of which there are almost 60 which are bad to you and 7 are known carcinogens. Category 1 carcinogens, they will cause cancer. And it's not just lung cancer. When you inhale the smoke of the cigarette, as it penetrates into your body, it is going to be excreted from the kidney. All the organs where it touches, it leaves its impact. So cancer can happen to the throat, to the food pipe, to the lungs, to the kidneys, to the bladder. So it can affect any organ from head to toe. It's not just that lung cancer is on a rise because of tobacco. So avoid these products. Have a lean body weight. I'm not saying that everybody becomes absolutely athletic, but there is a BMI range. Try to be within your range. If not obese, at least overweight se niche aa jao. If you are doing that, you are again avoiding the risk of 4-5 lifestyle-based cancers. Eat good, eat right, and I know it is a very difficult thing to do in today's time. We're all struggling with work-life balance. You want easy food, you want fast food, because you don't have time to invest into and do all that. But I see a lot of colleagues of mine having their own lawn terrace produce. Eat good. So eat more fruits and vegetables, have more fiber in your diet. Fast food once in a while is fine. Moderation is the key. Don't do excess of anything. So that will reduce your risk. And secondly, as you have already pointed out yourself, annual health checkup is the key. That is where we see the Western world is far ahead of us. We don't have mandates. There it is mandatory. Your health insurance forces you to go through those tests.
Exactly. I would like to interject over there. In fact, when we were in the US and I got married and my wife came over to the US, we went to the so annual health checkup is mandated by the insurance. So we went to the gynecologist and she was stunned. She said, she asked my wife, you've never had a pap smear test? And she was like, I don't understand, and she made a generic statement that all of you guys, when you come from India, I do not understand, why don't you get your pap smear test done in India? It is absolutely necessary.
I believe it must have not sounded well, but it is a reality. If I am addressing a group of doctors, even if we have 50 doctors sitting in a room and we ask for a show of hands, how many people have gone for a pap smear? You would hardly see 5 or 10 hands going up, because it's not a mandate, it's a choice. When you leave it as a choice, we have that avoidance, we don't, everybody feels that, main to theek hu. We live, we are immune. That wrong notion that we are immune to diseases is something which is very, very catastrophic. Diseases can happen to anybody. It doesn't discriminate between rich and poor, boy or a girl, a doctor or non-doctor. We've had colleagues who have died of this cancer. Very, very famous Padma Shri doctors got diagnosed at stage 4. So it is not that it will, the doctor got to know earlier than the others. It is unfortunate, but screening is the key. So you will be glad to know, today itself I saw a big banner in the hospital as walking down after the rounds. There's a big banner there right at the reception area which they have mentioned cancer screening packages. I just saw it today, so I was happy to note that I saw it today, and I'll be able to tell you that there's a package already in place. Irrespective of that, there is a full preventive oncology department even in our hospital running from last 25 years.
Preventive Oncology
yes,
Department.
but
And
people
what do they do?
People don't come. People fear. It's a absolutely free service where any woman who's married or sexually active can go for a free pap smear. Any woman who's more than 40 years of age can go for a free mammography. Any gentleman above 50 can go for a free PSA examination. So there is a dedicated doctor there, there's a social worker, there are nurses there for preventive, and they're doing camps. They're even doing screening camps across the city. There's a big bus which has been devoted for this screening purpose only. But people don't want to come because there's a notion, agar nikal gaya to. So that is how people perceive screening.
Yeah.
It should be other way.
What
is screening? Basically, what is screening? So screening is just like when you go to the airport and those policemen are screening your luggage for anything dangerous. So we as doctors are screening you for something dangerous in your body.
Yeah.
It may not be cancer all the time. It could be diabetes, it could be hypertension, it could be hypothyroidism, vitamin D deficiency, which is so common these days. So a lot of things you will not feel. So we don't want the diseases to throw symptoms. You don't wait for diseases to become unmanageable. Pick them up when they are just propping up. So that is, I think, the key for overall picking up diseases in early stages.
And this is happening in all Narayana affiliated hospitals.
I can vouch for DNSH because I see it, but in general,
DNHS is Dharamshila Narayana
yes.
Hospital,
yes.
right?
So rest places, they have their different way of addressing the screening, but the preventive oncology department dedicatedly is there at Dharamshila, and it has been in place for the last 25 years.
Wow, and we didn't even know about it. Thank you so much for shedding that light. I think everybody should go for it. My next question is, I think you partly answered that question, but I will still ask that for the benefit of the audience. What are the most common types of cancer that you are seeing? So both men and women, I know they are different, so both men and women, what are the most common type of cancer that you are seeing today?
So in our scenario, at least if I talk of the country per se as a whole, breast cancer in women is the most common. Previously it was just confined to the urban cities, but now we see a lot of breast cancer happening across the country. Second most common is the cervical cancer. Then we have the cancer of the lung also on a rise in women also. Okay. Colon cancers, and in men more so head and neck cancers. These are the oral cavity cancers, throat cancers, lung cancers. And of late, at least in Delhi NCR, I'm seeing a tremendous rise in prostate cancer also in men. Blood cancers are more the cancers of children. The young children are more afflicted by blood cancers. Lymphomas, leukemias, they are more confined to the younger age group. But majorly it is the head and neck cancers, lung cancers, breast cancer, cervical cancer, endometrial cancer, which is more prevalent in our country.
And what I've also heard is that breast cancer is more prevalent in the cities than in the rural areas. How truthful is that?
It is absolutely correct, because as I mentioned, it was previously the disease of the metropolitan cities. When overall in India cervical cancer was number one, in Delhi, NCR, Mumbai, breast cancer still was the most common because of the lifestyle. Breast cancer is a lifestyle disease. If you are getting married at a late age, you are having children at a late age, or you don't have children, you're a smoker, you're obese, these are few factors which are responsible for breast cancer. And mostly people think breast cancer is genetic. Every time you talk of breast cancer, genetics come into picture, and Angelina Jolie is the person discussed about, and BRCA gene is what we talk about. Yeah. But if you row the real proportion, it is only up to 8% of breast cancers which would be genetic in nature. The rest 92% are sporadic. They are lifestyle induced.
But I've heard one thing, right, ma'am, and I wanted to clarify with you that if mother and father both have had cancer, there's a very high chance that the child will also have cancer at some point of time in their lifetime, right?
So it is not that simple. So for example, if the father has been a smoker, then it is not genetic. It is something which he has earned himself. Okay. So it is the type of cancer, and then it is not just the mother and the father. You would want to see the entire pedigree. What about their parents? At what age they got cancer? Genetic cancers tend to come early. Talking of breast cancer, if somebody is getting in 30s, it is more likely to be genetic than somebody who got it in her 60s or 70s.
Okay.
So there are a lot of combinations which need to be analyzed, and here comes the space for those molecular oncologists. So whenever we have a situation where we feel that these cancers may be genetic, we usually encourage to go for some genetic counseling where they draw the pedigree from both the sides of the family, and they try to find out whether this fear of being genetic is real, or it is just a chance finding that there have been clustering of cancers in the same family.
Right.
And environment also. If the family is having water from the same area, I'm just in general talking about that they're staying in the same environment. If there is some pollutant which is affecting all of them, then it might happen. If you know, there's a big cancer prevalence in Bhatinda.
Yeah.
And there's a very famous movie also which was made on that. And there's a train which goes from Bhatinda to Bikaner.
Cancer train they call it,
yes,
right?
Yes. So that area has a lot of cancer because of the environmental pollution, because of a lot of fertilizers into the irrigation water as well. And this has been noted in Delhi NCR also. There was a program which was floated on ZTV. Our own hospital is responsible for engaging into the analysis of these vegetables which are grown in the Yamuna belt. And the program's name was Cancer Ki Thali.
Okay.
So they found alarming levels of heavy metals in the produce of vegetables and fruits which are being produced here in the Yamuna belt. Because it is getting a lot of industrial waste, the Hindan water, and a lot of industrial waste is coming here.
That is pretty alarming. Ma'am, I wanted to ask a pertinent question that, and there is always this confusion on this. So for example, when I had to take my mom for cancer detection, when she suspected she has breast cancer, so we straight away went to a surgical oncologist. And then the surgical oncologist did the complete regime, going to a medical oncologist, first surgery, then medical oncology, then, for radiation. And similarly, this sometimes it is the chemotherapy first, and then the surgery, then the radiation. Sometimes it is radiation first. So, what do you think? How if somebody is suspecting that they have cancer, and they want to go to a hospital and start their treatment, who should they go to first?
So see, firstly, if somebody feels that it might be cancerous, there's a fear of cancer, you should go to a center which has everything under one roof.
All surgical, chemo and radiation. And so most of them have it, right?
Yes. Of late, the cancer centers build in the infrastructure in such a way that everything is under one roof. Yeah. Because irrespective of whom you will see, there will be a multimodality tumor board where the doctors will sit down and chart down the treatment plan. The plan of care takes into account the guidelines that for this particular stage, what should be the treatment. Patient's body acceptance. If a patient is having a poor performance status, elderly, has a lot of problems, so sometimes they might customize. But the point of contact can be any one of these three, because effectively, ultimately, the treatment would be the same, irrespective of whom you interact with, because nowadays it is not a working in silos culture. It is like a teamwork between all the oncologists, and they engage on day-to-day basis on this. And in this team, not only the oncologist, when we have our tumor board, there will be radiologists, there are even our lab people are sitting there to give us inputs on the histology. So you can meet anybody. For the fear factor, I would say don't hesitate. You can even go for a gynecologist or a physician. At least they can send you accordingly as per their finding to the next relevant doctor.
So ma'am, now we'll get into your field. I understand radiation. There are 2 to 3 kinds of radiation is what my understanding is right now. The IMRT, the IGRT, I've heard about cyberknife, but would want to hear more, from your side. What are the different types of radiations that are there, and how do we go about it? I'll get into. I know you do get creative also. You have to, but we'll get there a little later. Just wanted basics of how the whole radiation thing works.
So see, elementally from the physics aspect, radiation is of 2 types. It is particulate or it is photons. So particles are heavily charged particles. So particles can be electrons, they can be protons. So these, what they do is, they enter the body, they release their energy at a particular spot and come to rest. So these are the particles. Okay. Photons are the ones which are like energy packets. They enter from one part of the body and they exit from the other part of the body. But while they are crossing the body, when they cross, they hit the DNA strands of the cells. The defective DNA is hit so that it cannot multiply. So that is the pure basic how radiation is working. From patient perspective, radiation can be of two types. It can be external, when the beam is coming from outside the body. There's a machine, we call it a linear accelerator. The rays are coming from the linear accelerator and are put into the patient's surface. Or it can be internal radiation, where you're putting some applicator or some tube inside patient's body, like uterine cancers. You're putting something into the uterus, and then there's a radiation source which is like a small pellet. It travels through a channel, goes inside the patient's body, gives the radiation to the duration we want, and then comes back and goes back into the machine jacket. So these are two, external and internal. So case to case, somebody requires external, somebody requires internal, somebody requires a combination.
This looks like a physics,
Yes.
Like a physics class to me.
Absolutely.
So all those guys who have questions on, why a doctor should study physics, hear the answer.
Right, absolutely, and it is a very, very pure radiation physics, and there's a subject of a radiation biology also, where biologically the impact of these radiations are being analyzed in studies, and the entire rule set system has been defined. So radiation has a lot of tenets to it.
So we basically use the photon way of it and not the particulate way of it.
So there are particles also used in certain situations. You must have heard of proton therapy. Certain centers have proton therapy. So protons are utilizing these particles to hit tumors, particularly those tumors which are at critically located position where you don't want any exit. So radiation is entering from one point, but it is not exiting. So like young pediatric patients who have brain tumors, because you don't want them to have late sequelae in life. So therein these particulate therapies are helpful. Or a recurrent tumor, you are trying to treat the same area again and again. So you can't be giving excessive radiation. So then these particles are very, very useful in those scenarios.
So let me help, simplify this, for the audience, that we are talking about a beam, coming in. So let's say there is a cancer tumor. It hits that cancer tumor, and it kind of burns that tumor off so that it does not multiply and it does not spread further. That understanding correct?
The burns word would not be something which would be very applicable to radiation. We know because that is how a community perceives it. The words used for radiation in general are sikai, as if some heat is going to come. So there would be not a feeling of a burning happening.
Correct.
But the cells would be damaged, and because the cells are damaged, so you will see the effects. So mostly what happens, the surface through which it enters, sometimes you will see a pigment there. So it feels as if something has been burned. So basically those cells are made dead. They are made incapacitated, that they will not divide. So
I have many questions on that. Actually, I'm getting more and more curious. So sometimes we see that the tumors are large in size, right? Sometimes tumors are very minute, very small, right? Now, is it that if tumors are large in size, they shouldn't be radiated and they should be surgically removed? And if tumors are small in size, they should be radiated. What's the guideline? Is there a guideline around it? How do you decide?
So things are not that simple. So see, it is a tumor for you. For us, it may be a different histology. If it's a lymphoma, even if it is 10 centimeters, it requires chemotherapy. It will shrink with chemotherapy. It doesn't require surgery at all. If it is a sarcoma, it is very, very resistant. It may not be, removed in totality by radiation and chemo. Their surgery is required. So it is the histology. It is the location also. Where is it located? Can you remove that place? If it is a tumor where that organ cannot be removed, or it is touching another organ which is elementally essential for life. So it is always decided on a lot of factors. Majorly, certain tumors like breast cancer, colon cancer, lung cancer, brain tumors, here surgery is the first starting point, because you want to remove the tumor. It is giving the reduction in the volume effect, and then based on what we found on that removed tumor, when you remove that tumor, that is sliced and each and every part of it is seen under the microscope. Right. And then there will be a 4 or 5 paged report which will mention a lot of things, which will give us cues that this is a tumor which might come back. Then we decide that this is a tumor, if it is going to come, it has a tendency to come back, what modality has to be employed, where will it come back. If it is likely to come back at the same location, radiation is required. If it is likely to come back to the lungs or livers, then chemo is required, because chemo will revolve all around the skin, because it will go into the circulation, it will go to all the organs, so chemo would be required. So there are a lot of combinations. It is not very simple, and surely guidelines are there, case to case, stage to stage, but 60% of cancers require radiation at some point of time, either as a sole modality of treatment or in addition to the surgery or as a palliation. Sometimes, there are tumors we can't cure, but they're causing symptoms to the patient. It is causing pain to the patient, or it is bleeding, it is causing pressure effect. Then you want to shrink it there. So then also radiation may be delivered. So it's a combination, and that is why we have a multimodality engagement. We all, oncologists, we sit together and define that what would benefit the patient the most at that standpoint of time.
And with regards to the targeted area, right? So sometimes it's very small, so you would I am just assuming this, and I'm just trying to visualize it. So if the tumor is very small, you would want a very thin beam going in. If the tumor is large, you would want a slightly bigger beam going in. Is that a reality?
So essentially, it is something what you are conceptualizing, but that is the word which you were using, IMRT, IGRT. So these are the newer technologies which we have in place.
Okay.
So previously we had a square collimator. The radiation was coming out from one instrument, we used to call it the gantry, and there was a square field. So a square field was falling on patient surface. So whatever was falling within the confines of that square was getting radiation, whether it is a tumor, whether it is a normal area. A small example, if I am treating a patient who has cervical cancer, bachedani ka muka cancer. So there is the urinary bladder, the urine bag in front of it, there is a rectum, the potty tube behind it. So they were also getting the same radiation as the tumor.
Yeah.
So eventually patient was getting cured, but at the same time was getting 30-40% risks of bleeding from urine, bleeding from stool because of the side effects.
Right.
But then now what happened, that we got newer machines which have feathering. Instead of that square, we have some interdigited feathers and leaves. So we can shape them. These can take shape of the tumor the way I want. So what we do now is we take a CT scan or MRI of the patient, and on those MRIs we draw these areas to be treated, and then there are our physics colleagues, medical physicists, who put some algorithms who would define the intensity with which individual beam will go. So instead of one beam, that beam is divided into beamlets.
Correct.
So you can modulate the strength of each beamlet in such a fashion that it's like drawing, it's like filling colors. We call this dose painting. So you can give differential dose to different parts into the body. So what you're able to do is you're able to give good dose to the tumor, at the same time protect the neighboring organ. Sometimes the tumors are just like that. This is the tumor, it is the other organ is just hugging. So how to save this organ? So these technologies have given us the capacity to save the adjoining organs.
Especially with the 360-degree thing that you have nowadays. I remember you were talking about that you will design, you will design the radiation in such a way that it comes from different parts,
Angles.
so that one organ does not get targeted many times, right?
So that arc is essentially the volumetric arc therapy. That the degree of freedom in the volumetric arc therapy is more. So our radiation plans are more conformal. So that reduces the time the patient has to spend onto the machine. So patient is comfortable in and out. Patient is just taking 4-5 minutes on the radiation couch. So it is very comfortable to the patients. So in addition to this intensity modulation, what came in next was image guidance.
Okay.
So now what we have is our linear accelerators are hybrid. Within the same machine, we have CT scans also, and now we have a machine which has an MRI also inbuilt into the linear accelerator. So when the patient is on the radiation machine, you can take a CT scan and verify and see what is happening real time in the body. So that is IGRT, that is called image guidance. So mostly this is the form of radiation which is practiced across the country. Though we know healthcare is polarized, there are segments of public sectors which may not have the facilities for IGRTs, where still the workhorse are the basic machines called the telecobalt machines. They do not have the capacity of IMRT and IGRT, but effectively, the big community is still being treated by them.
Good. And just wanted to know, what was the most challenging procedure of your lifetime which you will never forget?
So I think the biggest challenge which comes is when you're treating children, right? And I very vividly recall this was a 1.5-year-old girl I was treating, and I myself was expecting my son. So, many people feel that radiation is a hazard. Pregnant women cannot work around it. So this child was to be treated for whole body radiation, because she had to undergo a transplant, and the child wasn't very cooperative, and I was keen that she gets some sort of an anesthesia, but for some reason the family declined, and they said no, we do not want to put her under sedation, she may not come out of it. There were a lot of fears in their mind. So that phase when you yourself are nurturing a human being inside you, and then you're seeing these parents go through that struggle, that was enormous mental stress while treatment. It was not a technical, I would say, challenge. It was a mental challenge which I had to overcome. And then I supervised the entire treatment in a fashion that it had to be done early in the morning at 6 o'clock, because when we do whole body radiation for transplant patients, we create a green corridor. We don't want any patients or any other people coming in contact with that child, because the immunity of that child is very low. The white blood counts are very low, because for the transplant their body immunity has been suppressed. It was a very big challenge. So I think technical challenges come and go. We have means to address them. We read, we engaged in conversations with peers. There are means to address them. But mental challenges are something we don't talk about as doctors, because we don't want to show our vulnerabilities. But there are vulnerabilities in such situations, when you really have to pull yourself together, and it was enormously overwhelming for me. But I just went ahead with it. And everybody was like, why did you go yourself? You were pregnant, you shouldn't have gone. I said, I know as a doctor, there was no radiation exposure when the beam is not on. I don't want to give that wrong message to the other community also. When the beam is not on inside the machine, there is no exposure to me. But fortunately, things went well in place. And my son was hale and hearty, fit and fine, no sequelae. So again, reinforcing the fact that radiation in today's time is safe when done with military discipline.
Younger people who get cancer are more prone to a very aggressive kind of cancer, because their metabolism is fast, their cell multiplication rate is faster. What's the truth in that fact?
So there is some partial truth to it, because it is different for different histologies. For example, if I talk of endometrial cancers, for endometrial cancer, a woman who's above 60 years has a more aggressive cancer than the one who's lesser than 60.
Oh, okay.
For breast cancer, it is the other way. Usually the younger ones have a more aggressive biology. So it is the biological difference in histologies which predisposes to different risk factors. So for few cancers, for youngsters, we say it's good, like lymphomas in youngers, the leukemias in youngers are curable. But when these same cancers, leukemias in the adults may be more aggressive. So it is not limited to as a blanket statement, but histology to histology. In certain tumors, younger patients have a higher risk of disease recurrence because of the aggressive biology.
Thank you, ma'am. Now we are in the last segment of the podcast. Wanted you to touch base upon different stages of cancer. So we have 1, 2, 3, 4. How do you actually classify these into different stages?
So although organ to organ stages change,
Okay.
a 7 centimeter tumor for lung cancer is stage 1, for same 7 centimeter for breast cancer becomes stage 3.
Okay.
So elementally,
let's take
I'll give you an overview how we stage them. So if there is an organ from which the tumor has arisen, if the tumor is limited to that organ, it is majorly stage 1.
Stage 1.
If it comes out of that organ and goes to adjacent draining areas, for example, in breast it can be lymph nodes, in head and neck it can be lymph nodes, it becomes almost stage 2. When it infiltrates some nearby more structures, like for example in cervix it goes into parametria, it goes down to the vagina, it becomes stage 3. Stage 4 is when it goes beyond the organ of its origin to some distant organs. Like for breast, it may go into the lung, cervix going into lung would be clubbed as stage 4, where these cancer cells have got an access into the bloodstream and they're circulating all around. And they're going and finding space in different organs in the rest of the body and growing. That is stage 4.
And what I've heard is stage 1, stage 2 are like more than 90% curable.
Yes, I think we can take that message that at least stage 1, most cancers have 90% cure rates. For certain cancers, even stage 2 have very good cure rates, like vocal cord cancers, the cancers which are of the voice box, the vocal cords, even up to stage 2 we have 90% cure rates. Testicular cancers are gonadal germ cell tumors, even stage 3 have 90% cure rates. So again, there are different biologies behaving differently, but the norm is that the earliest you detect, the better is the chance of cure. Lesser would be the treatment required. Yeah. Lesser treatment modalities would be required. It will add to lesser side effects to you, lesser financial toxicity. We don't talk about it, but it is one of the driving factors in treatments at times. There may be the best of the treatment available at your disposal, but sometimes the family is unable to reach out to that. So there is a lot to talk about financial toxicity in our country, because here out-of-pocket payment is still 49-50%. It is not like the Western world where insurance has been taken by every person and there is somebody paying for you. So that also has to be accounted for.
That's absolutely correct. And with that, I think with that positivity, I would want to end. And the positivity is that if we detect cancer earlier, it is curable, right? And
you can avoid it. I liked your line. I liked your line. You can avoid it. Definitely, you can avoid your risks of getting these cancers. Don't smoke. Have a healthy lifestyle. This is the mantra. I think this, an annual health checkup. If the 3 things you can do right about yourself is avoid tobacco, alcohol, have a healthy lifestyle, and annual health checkups. That is the key.
That is the key. And with that key, thank you, ma'am. It was, I would say, an enlightening experience for me. I got to learn a lot, and I'm sure the audience would get to learn a lot as well.
I also enjoyed the conversation. I think it opened up a lot of memories. I went into nostalgia a few times on certain questions. It was an engaging one. I enjoyed the conversation. Thank you.
Ma'am.
Thank you for having me part of this.
Thank you very much for joining in. So that was Dr. Kanika Sood Sharma enlightening us on the aspects of oncology. I would like to request each one of you to maintain a healthy lifestyle, to have annual health checkups, and with folded hands. Please stop consuming tobacco. Please stop smoking. This is a request. ये मेरी विनम्रता से एक सबको रिक्वेस्ट है. Please stop smoking and stop tobacco, and maintain a healthy lifestyle and do your annual health checkups to try to avoid cancer. With that, thank you very much for joining in. Do like, share and subscribe Tech Talk with KD. We will be back with another episode very soon. Keep tuned in. Thank you.